If anyone has difficulty with accessing the SOAP note and quiz or any of the other links in there, then please let me know. Or if you see people in the chat who are hopping on a little later who can't access it, then it would be super helpful if someone could just copy and paste it again. But without further ado, my name is Olivia. I've done a couple of these in the past and I really, really enjoy doing them. Today, we're going to be talking about an OBGYN topic, which was, I think, out of like maybe 20 or so people who responded to or gave feedback on the last session that I did, like 3 or 4 of them specifically wanted an OBGYN topic. So I'm not personally going into OBGYN. I'm right now interested in general surgery, but I did a 6-week clerkship in OBGYN, and this was definitely something that came up a lot. And I think that would be beneficial to have knowledge of in any medical field. So that's going to be what we do today. As always, we're going to be going through kind of a patient case, which will include a physical exam and differential diagnosis. And then we're going to kind of go through the pathology of the disease and how it will relate to our assessment and plan. So it works really well if you guys participate actively and ask questions and respond to the questions that I have in here, and support and encourage each other like you always do. And that'll be what helps people get the most out of these sessions. And then also, like I said, the SOAP note and quiz if you'd like to get a certificate of completion. And please also provide us feedback as well, because we really do listen to that. I'm going to start our case now. So we have a patient who comes to clinic, and she's a 29-year-old G1 P0 female who is 35 weeks pregnant in 2 days. And she's here for just a routine prenatal visit. So, as most of you probably know, the normal length of gestation is 40 weeks, which is approximately 9 months from your last menstrual period. So she's pretty close to being done with her pregnancy. She's almost term. And what are some things that you guys would like to ask our patient? She's, 35 weeks pregnant. I'll explain this notation, but this is also her first pregnancy, this G1P0. That'll be the next slide if you're wondering about that, but this is her first pregnancy. Imagine you're just conversing with someone who is like a coworker or a friend. What are some things you want to know? Yeah, diet could be a good one. Sleep, yep, excellent. Just like general lifestyle things, yeah. Like how's she feeling? How's she coping with this? Is she having any pain? Does she have any unusual symptoms that have changed for her? Does she have any concerns? A lot of that is, in OBGYN counseling and doing preventative guidance and sort of helping to reassure the patients of things, because this is a very new and sometimes scary experience to go through. So generally, patients have a lot of questions, and you're going to be their number one point of contact for providing answers. Prenatal vitamins is another excellent one. Yeah, you guys are right on the right track. So, like I promised before, G's and P's. So, this is a notation that's used to explain how many pregnancies and what the outcome of those pregnancies that a patient has. So, if we go back here, this patient was, I don't know if I can go back, sorry. She was a G1P0. So G is the number of pregnancies you have, which is gravida. So with her being pregnant right now, this is her first pregnancy, she's a G1, and then P is the number of actual living children that you have. So she's P0 because she hasn't had her baby yet. But this is further broken down into term deliveries, preterm deliveries, miscarriages, abortions, and ectopic pregnancies, and then your total number of living children. So there's actually 4 numbers that come after the P. So for example here, I know this can sound a little bit confusing, so maybe doing this will help. A G3 P1011. So G3 means she's had 3 total pregnancies. P1, so the first one is a term delivery. Second is preterm. Third is miscarriage or abortion. And The last number is total living children. So she's had 3 total pregnancies. She's currently pregnant and has had 1 live term birth and 1 miscarriage, if that makes sense. A G2P2002 is someone who has had 2 pregnancies and 2 term births with both of their children currently living. And then a G4P0131 is someone who's had 4 total pregnancies. And if you add up all the numbers at the end, they should equal the G. If it doesn't, then that means that they're generally like they already are pregnant. So this person has had 1 live preterm birth, 3 miscarriages, and not currently pregnant. So I know that can be a little confusing, but just so that you're aware, mostly to see what our patient is a G1P0, that means that she's currently pregnant and this is her first pregnancy. So that's not really the point of this talk, but it is definitely a confusing thing and something that you'll see later on. So G will always be the total number of pregnancies. That's correct. Yeah. Great question. We'll move back on to our case. So you guys hit a lot of these questions that we wanted to ask her. How's she feeling in general? Does she have any questions about her pregnancy or plans for delivery? Does she have any signs of preterm labor? Things like that could be contractions or feeling like your water has broken, or those are like the big things that we ask them. We ask about like fetal movement, if they're feeling their baby moving a lot. There's some pregnancy complications that we would want to ask about, which we'll kind of go into a little bit later, that we would want to kind of just do a general screening for. And then another important thing in a 3rd trimester, when this person is very close to delivery, what are their plans for contraception after delivery? Because sometimes, in the mix of going to the hospital and delivering your baby and then taking them home, it's not always discussed. It's supposed to be discussed, but sometimes it just doesn't get talked about before they're discharged from the hospital. And you always want to have a plan for how you're going to prevent another pregnancy from happening in a very short interval after delivery. So those are just some example questions. These don't have to be the exact ones that are asked at this visit. In general, the point of prenatal visits is really just to check in with them and be able to answer their questions and support the patient in whatever way that they need. So for our case, the responses to these questions, she is feeling well, but she's having some occasional headaches. The headaches, she said, they started about 1 week ago. And over the last 2 weeks, she's also had more severe. Hey guys, I'm sorry. I don't know if that was just my internet that cut out, but I got disconnected. So I'm going to just pick up where we left off. I apologize for the technical difficulty. Did we talk about the past medical history, or do I need to go back more? On HPI, okay, thank you for that. Sorry, guys. Okay, so going back to the HPI, she started having headaches about 1 week ago, and she's had some more ankle swelling. And I was saying maybe this part got cut off, but if a person who's 35 weeks pregnant, it's not uncommon to have ankle swelling at this, part of your pregnancy, but it's also something that should be like looked into and get some more information on. So the headaches and the ankle swelling are the two new things for her. So for her past medical history, she has a history of childhood asthma. So this is presumably well controlled for her now. She also is taking a prenatal vitamin, which the most important part of a prenatal vitamin is to have a folate supplement or a folic acid supplement. And the reason for this is because it prevents neural tube defects in the pregnancy. This is more so important in the earlier trimester, like the first trimester, meaning the first 12 weeks, but it's definitely recommended to be on it for the duration of your pregnancy. And it's actually also recommended that all women of childbearing age, regardless of your intention of pregnancy, to be on a prenatal vitamin at all times anyways, because it is a very like low risk, high reward type thing if there were to be an unplanned pregnancy. And then also she is adopted, so there's no family medical history on file for her. For her social history, she works as a 5th grade teacher and has been married for 2 years. Pretty standard, I would say, for most of our prenatal patients. And now we're to the physical exam. So this will be for the objective portion of the note. We always start with looking at her vitals, and right off the bat, we're very concerned that her blood pressure is 150/92. This is already concerning in a person who's not pregnant because they are definitely hypertensive, but we're even more so concerned of it because of her pregnancy status. And we'll talk about that in way more detail later in the presentation. Her heart rate, she's still technically normal there. Heart rate ranges from 60 to 100 beats per minute in a normal person. Respiratory rate is 14, and that's also pretty unremarkable. She doesn't have a fever. Her temperature is 37 Celsius, and she is satting well on room air. She has a good oxygen saturation at 99%. We do notice that her BMI is 36, so she is classified as obese by the BMI calculation. And she also has a fetal heart rate of 152. So it's a little bit interesting with pregnant patients because we not only are caring for the mother, but also the baby. And so we also want to pay attention to and be tracking the fetal heart rate. So for fetal heart rate, the range of normal is different than in a fully grown adult person. That's really hammered home in pediatrics, is that children are not just little adults, is what they like to say. So they have different physiology. And in a fetus or newborn baby, they have higher resting heart rates that are normal. So this is a totally normal fetal heart rate. On physical exam, the picture here, we're just demonstrating the finding that she had talked about with the ankle swelling, but we'll talk about that in a second. She has normal cardiac exam, regular rate and rhythm. Her lung exam is unremarkable. She has clear and equal breath sounds. For her abdominal exam, she is gravid. Gravid is the Latin term for like pregnant, so that's expected for her. She's 35 weeks pregnant. And she also has a fundal height of 31 centimeters. And I'll kind of go into what the implication of that measurement means on the next slide. But just keep that 31 in your head for a couple seconds. And then she also has mild tenderness in the right upper quadrant. In the extremities, she has this 1+ pitting edema bilaterally. That's what's illustrated in this photo here. So you can see her ankles are looking kind of puffy. Her skin is maybe a little bit more shiny because it's more distended and swollen. And if you were to press on her ankles or her shin with your fingers for a couple seconds and then let go, then you would see like an indentation where the swelling is. So that's what that 1+ means. And then for her neuro exam, she has 3+ patellar reflexes bilaterally. That is a hyperreflexic number. So typically we see 2+ for reflexes, and this is just meaning it's exaggerated. So when you do her like hammer on her knee with the reflex mallet, then her knee jerk is like more exaggerated than you would see typically. And then lastly, as this is an OBGYN topic, her pelvic exam was unremarkable. Her cervix is at 0 centimeters, 0% effaced, and -3 station. So I understand that a lot of this might be confusing right now, but I'm going to kind of go into more detail with it a little bit like in the next couple slides. So just bear with me. The highlights of this slide are that she has a high blood pressure. She has a fundal height of 31 centimeters, and she also has this pitting edema in her ankles. Before I move on, do you guys have any questions at this point? I know you probably do with some of these numbers, but I'm going to go through those. I just wanted to see if there's anything I can clarify before we keep going.
What is the average fetal heart rate?
That's a great question. So we would expect it to be between 110 and 160 beats per minute is the normal range. So this number is like beautiful and perfect. We wouldn't want it to be any different than it is. It's a great question. Anything else I can clarify? Sarah had asked if this video is posted on YouTube. Yes, it will be posted probably in the next couple of days is usually when Becca's able to get them up. So you will be able to go back. And I forgot, but I can also post the Google Drive link to all of our PowerPoint presentations so you can go through them on your own time as well. Okay, we'll keep going. All right, so we're going to talk about the fundal height really quick. This is a physical exam maneuver that we do for pregnant patients, and essentially it's a measurement that is able to help correlate the growth of the baby with how many weeks along the mom is. So what you do is essentially measure the baby bump starting from the top of the pubic bone. So that's kind of down here by like this 12 to 14 weeks dash line. It would be a little bit below that mark. And then you go all the way up to the fundus of the uterus, which is the top of the uterus. So these markings are kind of indicative of approximately where the baby would be depending on how many weeks pregnant you are. So at our patient being 35 weeks, we would expect her to have a fundal height of 35 centimeters, plus or minus 2 centimeters, depending on how big or small the baby is. So the fact that she's 31 centimeters means that she is actually smaller for her gestational age compared to what we would expect, because at 35 weeks, we would expect it to be 33 to 37 centimeters. For fundal height, they would be laying down. They would be essentially laying flat or at like a 45-degree angle, because sometimes when you're very heavily pregnant, it's not comfortable to be completely flat. So we do take that into consideration, but it's definitely not a standing measurement. This will be laying flat. That's a great question. So with our patient expected to be between 33 to 37 centimeters, we are a little concerned that her baby is small for gestational age at this point in time. Any questions about fundal height? Again, it's not like a super diagnostic finding. It's more so just like a way to check the progress of the baby's growth as an estimate. And then you can get more accurate numbers by doing an ultrasound. But yep, from top of the pubic bone to the fundus of the uterus is how you measure that. And then we're going to go through a quick pelvic exam for pregnant patients, because you can't do an OBGYN talk without talking about this. So the 3 numbers that are included in a cervical exam is the number of centimeters dilation, the percent effacement, and the station of the fetal head. So essentially during the process of labor, your cervix goes through a transformation called cervical ripening, and that's the process of both dilating and thinning out to accommodate the passage of the baby. So this process can take a very long time, especially for first-time moms. It's not uncommon to have it take longer than 24 hours. And that's kind of what we would call labor, that in conjunction with uterine contractions. So looking at the or the number of centimeters dilated, that's the actual distance from each end of the cervix that you're able to have a separation between. And then the percent effacement is the like thickness of the cervix. So typically it's a couple centimeters tall. And then as it becomes more effaced, it gets gradually thinner and thinner and thinner until it basically is just, non-existent. And you can kind of see this in the illustration as well. In the first one, it's not effaced. In the second one, it's fully effaced, meaning it's very thin. And then at fully dilated, it basically just recedes all the way to the walls of the uterus. And then lastly, the station refers to the position of the baby relative to the pubic bone. So the higher, if it's a -3 station, which our patient was, the baby is sitting very high in the pelvis. And if it's a +3 station, then the baby is like exiting through the vagina, like right now. So that's kind of how we measure progress in labor. Again, this is just more so for your own knowledge and not the main point of this video. So hopefully this is helpful to you. But if it is too confusing, then don't worry about it at this time. Any questions about fundal height or cervical exams? And we can always come back to this too. I'm just going to keep us moving along. Okay, so for our patient, she's experiencing kind of a cluster of symptoms right now. She's got reported headaches. She's got ankle swelling. She has this sort of right upper quadrant pain in her belly. So this could be a lot of things at this point. They all sort of seem unrelated. So if we think of them in like a systems-based way, the things that headache could be, they could be migraine headaches, they could be tension headaches, they could be dehydration. Those are just a couple of examples. For her right upper quadrant pain, if we think of the organs in the right upper quadrant of the abdomen, if any of you guys came to my bowel obstruction virtual rounds a couple months ago, we talked pretty extensively about the different quadrants of the abdomen. And that would be like the gallbladder, which would, if that was inflamed, be called cholecystitis. Pancreatitis is another thing that can cause that type of pain. And then swelling also has a very broad differential. It could be anything from heart failure to kidney failure to just like she maybe sprained her ankle and it's swollen on one side. So right now, there's not really a clear unifying diagnosis for these symptoms, which is sometimes you don't have a very obvious thing that's causing your symptoms all the time. You might have to kind of look at them individually and then think about a bigger process that could kind of tie them all together. But at this point, we want to, be thinking of the things that are the most serious and then exclude those. So the fact that she doesn't have any like other signs of infection, we can probably knock off these like right upper quadrant organ inflammation states. Her headaches, they seem to be pretty frequent for her. So these things might not be explanatory of that. We could go probably make a whole video about like clinical reasoning of working through a differential. But at this point, I just wanted to show you guys that there's really nothing that we can pin on what she has at the moment. Going through some more specific things, however, there is kind of this category of pregnancy complications called hypertensive pregnancy disorders. And that's the spectrum of disorders that is present only in pregnancy, that can pose a threat to mother and baby if they're not treated. So they're very important to screen for and to diagnose correctly. One of the biggest things that we want to differentiate in these hypertensive pregnancy disorders is is it truly a pregnancy disorder or did it exist prior to the pregnancy? So for someone with chronic hypertension, somebody who either had it before they became pregnant or it maybe started when they were pregnant, but it's due to a process that's not the pregnancy. That has to be diagnosed before 20 weeks. That's the halfway point in the pregnancy. If you remember, it's 40 weeks. And that's for reference, like, I think it's, what is it, 5 months pregnant. So in our patient, she's 35 weeks. It's very likely that this did not exist for her before the pregnancy, and it's something that's like an actual hypertensive pregnancy disorder. Gestational hypertension is the onset of high blood pressure after 20 weeks, but in the absence of other symptoms and lab findings. So we don't know yet if she has gestational hypertension or if she has other more serious hypertensive pregnancy disorders because we haven't done any workup for her yet. The ones that we are most concerned about are preeclampsia and HELP syndrome. So preeclampsia is essentially gestational hypertension, which is the high blood pressure after 20 weeks, accompanied by protein in the urine and organ dysfunction. And then HELP syndrome is kind of a mnemonic or an abbreviation for hemolysis, elevated liver enzymes, and low platelets. So this is a very serious complication of pregnancy where your blood pressure is so high that it's literally causing organ failure. It's like your liver is failing and your platelets are low, so you're more prone to bleeding. It's definitely not a good place to be. And then eclampsia, if you'll notice, it's like preeclampsia, but eclampsia is the result of untreated preeclampsia that progresses to essentially seizures and coma. So it's very rare, especially in the US in this day of modern medicine, that preeclampsia would progress to eclampsia. But when it does, it's extremely serious and has a very poor mortality and morbidity. So we do everything we can to try to get it to not progress to that point. So with this being said, there's a couple things on here, I guess, that can maybe give you hints, but what are the tests that we would order to try to figure out what her diagnosis would be? Urine, perfect. Yeah, just a general urinalysis even would be very helpful for us. A CMP, excellent, yep. CBC as well. Yeah, that could help us with the like looking at her platelets and if she has hemolysis going on. That's perfect. What other organ system would we want to look at? Specifically for HELP syndrome. We've kind of hit on the H and the LP, but what's the EL in there? Perfect. Thank you, Kathy. Yeah, so there's kind of a general series of labs that we do for these hypertensive pregnancy disorders, and that's like a urinalysis, liver enzymes, and CBC essentially are the ones that we especially care about in trying to work out what the diagnosis of high blood pressure could be. So we did, well, I guess we'll reveal the results of this. But essentially we would want to first confirm the blood pressure and compare it to her prior visits. So maybe in this case, and this is the case for a lot of people, if they're just extra stressed out or if they had just walked up a flight of stairs and sit down in the chair and get their blood pressure measured, it's usually going to be higher than it actually is at rest. So we always want to give them a chance to kind of sit down and relax and have both their feet on the ground and take some deep breaths and just sort of relax before remeasuring their blood pressure and then see if it goes down. And also to compare it to her prior visits, because if she had a a jump in blood pressure from normal to 150 systolic over a couple of weeks, then that's more likely to be this sort of pathologic process versus something that would onset gradually. And then for labs, like we just talked about, are trying to rule out having preeclampsia or HELLP syndrome. So we're looking for protein in the urine. You can do that with a urinalysis or a 24-hour urine collection. The 24-hour urine collection is the gold standard compared to the urinalysis, but both are usually ordered. We also look at liver enzymes, which would be ALT and AST, renal function tests to look for the clearance of certain metabolites in the urine, and then a CBC, so specifically looking at platelets. And then regardless of what the outcomes for these labs are, we want to start empiric treatment for blood pressure control. We don't want to let this go untreated while we wait for the results. So we're going to begin empiric treatment. So for our patient, we remeasured her blood pressure and we saw that she was still hypertensive at 148/90. 2 weeks ago, it was 123/83, which was very close to normal, but still maybe a little elevated. So the fact that she's progressed to this point in 2 weeks is certainly concerning that she has a hypertensive pregnancy disorder. And her urinalysis showed a 2+ protein in the urine, with her 24-hour collection is still pending, but this is still solid evidence that she has protein in the urine. And then her liver and kidney function were within normal limits. So that's good. That's reassuring that she does not have something like HELLP syndrome. So at this point, she has high blood pressure and protein in the urine. If you remember back to her physical exam, she also had the swelling of the ankles, and that can be caused by high blood pressure. So when you have increased hydrostatic pressure in your capillaries, like down by your feet, especially with gravity sort of pulling a lot of your blood down and kind of creating this congestion in your circulation down there, then the increased pressure will kind of force fluid out of the blood vessels and into your interstitial space, and that can cause the ankle swelling. Just kind of to correlate the exam with what we're seeing as her diagnosis. Does anyone have questions at this point about the labs or the workup that we did for preeclampsia? So we can keep going, and then if anything comes up, then we can always go back to. So our final diagnosis for this patient is preeclampsia without severe features. And like I said, the empiric treatment for high blood pressure is to give an antihypertensive. They're a little different in pregnant patients than in regular, like non-pregnant patients. So the one that we're going to do is nifedipine. And this is a calcium channel blocker. And the reason for that is because it is not a teratogen or like something that can cause birth defects. So moving into the pathology, this is a nice little illustration that I found from MedComic. There's a lot of resources out there like Sketchy, and I think there's one for biochem, and then this MedComic that kind of goes through the pathology, and they're really nice to help do like visual mnemonics for these different disease processes. So this is one that I found for preeclampsia. We'll go through this in a little bit more detail, but we're looking at this placenta that's kind of looks like it's holding its breath and, you know, not getting very much blood. And we have on the mom's side this blood vessel that's really constricted, and the kidneys and the liver are crying out for help. So we'll go through those in a little bit more detail in a couple of minutes, but I just thought maybe this would help to stick it in your mind. And the slides will be posted in the Google folder. I'll actually put those in really quick so you guys can maybe, follow along here. Okay. I'm gonna paste the link for all of our presentations in here. And so you guys can have this pulled up because I think a couple people have asked for it now. So this presentation and all the others should be in that folder. And this one is the OBGYN preeclampsia presentation. Okay, so moving on to more of the pathology. So we do know of a couple risk factors that can be associated with preeclampsia, although we don't know exactly what the specific cause is. So some of the risk factors are things like obesity. If you remember, our patient had a BMI of, I think it was 36. Women whose it's their first pregnancy and being over 35 years old. Also having twins or multiple gestation because you have multiple either multiple placentas or multiple fetuses that you have to supply blood to. And the hypothesis for what causes preeclampsia from a pathologic standpoint is that you have these spiral arteries that you can see kind of coming off of the umbilical cord here. There's all these smaller arterial blood vessels that are feeding the placenta with blood. And the thought is that they are not able to remodel appropriately to accommodate the growing placenta. And so they aren't able to just like keep up with the oxygen and nutrient demands. And therefore, the mother's response is going to be to increase her blood pressure and her systemic arterial resistance to try and better perfuse the placenta. So the whole point of it is to just try to get as much blood from the mom's body to the placenta as possible, but it's going to increase the blood pressure everywhere in her body, including the kidneys and the liver and the feet and things like that, and the brain as well. So you get all this like end organ dysfunction, and because of the decreased placental delivery of nutrients to the baby, that's why you get this intrauterine growth restriction. If you remember with her fundal height measurement, it was 31 centimeters. That's smaller than what we were expecting. The fact that this, placenta wasn't able to meet the needs of a growing baby that helps to explain why we saw a smaller measurement than we were expecting. So I know that this is kind of a complex slide, but the takeaways from this are that we know a couple risk factors, like being obese, having your first pregnancy, being over than 35, and having twins or multiples. The actual pathologic process is this placental insufficiency, and that leads to all of these other symptoms that we've already discussed. Does anyone have questions about the pathology or how to correlate it with some of the exam findings that we found? Cool. Yeah, I was a little nervous because with this topic, like I said, there's not a specific known proven cause. These are just still kind of hypotheses for what causes preeclampsia. But if you kind of think the process through, it does make sense, that the placenta isn't able to meet the needs of the baby. And so you get this compensation on the mother's side. Okay, so we're going to talk a little bit more about treatment. So if you remember, her diagnosis was preeclampsia without severe features. Whether they have severe features or not is kind of going to guide our treatment. So what are severe features? The severe features are having a blood pressure more than 160 over 110. That's what we would call a severe range blood pressure. And then you would also have some more scary neurologic symptoms like vision changes or blurry vision, organ dysfunction, like we talked a little bit about with HELLP syndrome, if your liver and kidney markers are elevated. But sometimes you can just have like complete organ failure and shutdown. We kind of talked about a little bit with the swelling and how the increased blood pressure can cause forcing fluid out of the blood vessels and into the tissue. That's the same mechanism for why you would maybe get pulmonary edema or fluid in the lungs. And that can cause shortness of breath and low oxygen because you're not able to get air from the lung space into your blood. And so that's obviously not good. And then, as we mentioned before, with eclampsia, that's going to be when you start to get seizures from the brain having so much dysfunction and such high pressure that it causes seizures. And that's very bad. So, what do we do for this? We give magnesium sulfate. So sorry, I'm going to backtrack a little bit. So first, we want to get them stabilized. We're going to admit them to the labor and delivery unit for their treatment, especially if they have severe features. If they have preeclampsia without severe features, this can be managed outpatient. But if you have any doubt that they are in any sort of jeopardy, then you would want to have them hospitalized in an L&D unit that's equipped to be able to help handle this condition for them. The absolute cure for preeclampsia is to deliver the baby, because then when you don't have a placenta that's causing your body to have this systemic hypertension, then the cause is removed and you essentially go back to normal. In a person with severe features, if they're completely unstable, you would do an emergency C-section to get the baby and the placenta out, and not just wait for a vaginal delivery. But if they're stable and they don't have severe features, and they still have a couple more weeks left before they go into labor, then it's also reasonable to just watch carefully and await natural labor or induction if they are stable. You do want to get IV access in someone who is unstable and who has severe features so that you can give medicines through their IV. So, like I said before, you're going to empirically give antihypertensives. This would be nifedipine, or a couple other drugs that we'll talk about in a second. And then the big one here is a bolus of magnesium sulfate. So if you remember, when you have really high blood pressure and you're just systemically vasoconstricted, and I think Madeline, this might answer your question. Even the blood vessels in your brain get very, very small and constricted, and that can cause less blood supply to your neurons, and they can kind of go into this like electrical frenzy. So with magnesium, it will induce cerebral vasodilation to help relax those blood vessels and increase the blood supply to the brain. And that will help to prevent seizures because your neurons will have more electrical stability. And with the magnesium, you can get the opposite effect. So if you remember, she had a increased reflexes when we did her patellar reflex, and she had like more of a knee-jerk response. With magnesium kind of reversing this cerebral hypoperfusion, you can also get magnesium toxicity. So that's something that we would want to monitor closely for. And when you end up doing your OBGYN rotation, that's a very classic med student task, is to do mag checks or magnesium checks. And you go in with your reflex hammer and you do all the reflexes and you ask them these sort of questions like, how's your vision, and all these sorts of things. And that'll kind of clue you into not only how their preeclampsia is being controlled, but also if they're having magnesium toxicity. So with the high blood pressure causing seizures, it's essentially a neuronal response to low oxygen conditions. It can happen in things like traumas, if you have really bad bleeding, or if you have like a stroke that's really severe and you lose blood supply to a certain part of the brain. Seizures are just kind of like an end stage sign of brain damage, essentially. So this magnesium is going to help to prevent that. It's neuroprotective. Any questions about treatment for preeclampsia right now? We kind of have this flow chart, are they stable or are they not stable? If they're not stable, you hospitalize them, you get them these IV drugs. I guess I didn't really make it super clear, but our patient at this point, because she doesn't have severe features, she would be a stable patient. She doesn't need to be admitted and having these, more intensive treatments. We could probably manage her outpatient with a, uh, you know, nifedipine or another antihypertensive, but we would want to watch her very closely for potential to have more severe features become apparent. And how would edema be reduced? So hypothetically, when we reduce the blood pressure, you would get less um, fluid in the tissues accumulating because there's less pressure pushing it out from the blood vessels. So that would hopefully be reduced with the treatments. But then you also can do non-medical treatments like compression stockings are kind of the big one, and limiting your salt intake or some other things as well. But typically, you would have some of it be expected because of pregnancy, but then the main thing is that we would want to just make sure that their blood pressure is controlled, and that should hopefully take care of the problem. The reason for nifedipine, that's a great question. I'm glad you brought that up because it's on my next slide. So the diagnosis for this patient is preeclampsia without severe features. We're going to do nifedipine because it's not teratogenic. I'm not sure how much knowledge you guys have of other medicines that are used to treat hypertension. The big one that a lot of people know of is called ACE inhibitors, and that would be something like lisinopril. That's like kind of our first line for non-pregnant patients with hypertension. And the reason we don't use that is because it can cause birth defects in the baby. So there's this fun little mnemonic that we learn called Hypertensive Moms Love Nifedipine, and it stands for the 4 different types of blood pressure medicines that we can safely give to mom. Again, that's because they don't cause birth defects if they take them in pregnancy, and they are all effective at reducing the blood pressure that can cause these symptoms of preeclampsia. So any of these from this list will work, which I didn't even say what they stand for, but it's hydralazine, methyl-dopa, labetalol, and nifedipine. I just picked nifedipine because it's the same in both the mnemonics and the actual drug that it stands for. And also just coincidentally, I think happened to be the one that I saw the most commonly used during my time in labor and delivery as a student. So you could use any of these, but the main point is that they are not teratogenic. To wrap up our case, our patient went into spontaneous labor at 39 weeks. She had a vaginal delivery without any complications. Her baby was small. It was about 6 pounds, 8 ounces, but otherwise totally healthy. And mom's blood pressure went back to normal after delivery. So, I just wanted to show this picture of a cute baby being born. But Emerald had a question about what are some signs that she could look for at home to indicate things are getting worse or better. That's another great question. So again, at these prenatal visits, we're providing sort of anticipatory guidance for things that could go wrong and making a plan for when to check in. So at our visit, we would sit down with the patient and say, hey, we have this new diagnosis. You have preeclampsia, and this is what this means. We'd go through kind of how it happens and what her diagnosis is, the findings that led us to the diagnosis. And then we would also let her know what some of the symptoms are to look out for. So like we said, the kind of blurring of vision changes, really severe headaches that are changing for her and not just the ones that she's been experiencing for a couple weeks now. If she has really worsening right upper quadrant pain, trouble breathing, that could indicate pulmonary edema, sort of just all the things that we've already talked about. If they just get worse for her, then that's definitely a sign that we want her to come back in and get reevaluated. And then sometimes we also give patients a home blood pressure cuff that they can measure their blood pressure with, just like when they're at home and relaxed, and it should hopefully be the lowest that it would be at any time while they're at home. And so if they are concerned, that can also just provide some peace of mind that, if they are feeling worse, but their blood pressure is still not in a severe range, that they don't have to come in or go to the labor and delivery triage. And if they are in the severe range, that they know what to do from that point. And the answer is always going to be come into the hospital and get it checked out by the doctors. That's a great question. What other questions can I answer for you guys? I know we kind of wrapped up quickly here and we kind of had a very broad whirlwind of OBGYN topics in this presentation. We talked about fundal height and cervical exams. We talked about the G and P notation. That was really confusing and a lot of numbers. Anything you guys want to go back to?
So since this is her first pregnancy, would she have a higher chance of getting preeclampsia because she got it her first time? Like if she were to get pregnant again?
Yeah, that's a
Very
great question. So, like we said, the risk factor for preeclampsia is a first-time pregnancy. So, but I did not put on that slide that having preeclampsia in previous pregnancies also predisposes you to having it in subsequent pregnancies. It would be less likely if you didn't have it in your first pregnancy and then say your second or third that you developed it. But it's not impossible. And again, these are just kind of associations and not hard, fast rules. But that's a good question. Yeah. So she, as a first-time mom, this pregnancy did have that risk factor and could also have it in her subsequent pregnancies as well. What other questions do you guys have? If not, then I will unofficially wrap up this video for the sake of the YouTube posting that Becca will put up. And thank you guys for tuning in. And if not, then we just still have a couple minutes. I'd be happy to talk about non-OBGYN topics relating to medicine or applying to med school or any other things that you guys have for me. I guess I didn't really introduce my background, but I'm a third-year med student at the University of Iowa, and I'm super passionate about mentorship. I'm the first healthcare person in any field in my family, so I also know the struggle of kind of having to forge your own path into medicine. So if there's any questions or advice that you guys need at all, then we can chat about that towards the, okay, wait, we have another question. So obesity was a cause person with normal BMI get preeclampsia. Yeah, so obesity itself is not necessarily a cause, it's another risk factor. And people who are not obese can also definitely get preeclampsia. It's more so about how their placenta is able to adapt to the needs of the baby. And that's something that's just associated with obesity, but not necessarily like a hard and fast cause. So a woman with a normal BMI absolutely could still get preeclampsia. How far along in pregnancy does preeclampsia usually begin? So I think what I've read is that it typically onsets after 34 weeks, but remember it has to be after 20 weeks in order for it to be classified as a hypertensive pregnancy disorder. So even though the cutoff is after 20 weeks, it's less common for it to be in that second trimester. But then once you get into like 32, 33, 34, 35, it's more common to start happening then. Anything you can do to prevent it? That's a really good question. I honestly don't know. I think that probably just being really diligent with general health maintenance and trying to have a good BMI and in general also, you know, the recommendations is to have pregnancies before age 35. Those are some of the modifiable risk factors that we had talked about that might change your chances of having preeclampsia, but in terms of the actual cause, like with the placenta, I don't know if there's anything that you can do just to be really on top of it with making it to all of your prenatal appointments and adhering to the screening recommendations. And if something is found to be wrong, that you just take action and stay really diligent about it. That is a really excellent question. Would BMI be skewed if you're pregnant? That's also a great question. So we generally will look at the woman's pre-pregnancy BMI when we're looking at weight in pregnancy. So depending on how you are before getting pregnant, that will kind of dictate the recommended weight gain throughout your pregnancy course. So someone who is underweight or has a more normal BMI is encouraged to gain, I don't know the exact numbers, but I think it's maybe like 30 pounds. That might be too high. I'm not sure. And then the more overweight or obese you are, is you'll be advised to gain less weight, if that makes sense. So we don't use BMI necessarily. Like if you have, a woman who puts on 40 pounds in their pregnancy, it's not like their BMI is suddenly gone up from a normal range to an obese range in a matter of months. It's a physiologic weight gain that is expected because of the increase in her blood volume and the uterus size and the actual fetal tissue that's growing. There's a lot of things that goes into that. But that's a really great and interesting question that I'm glad you brought up, because we do really put a lot of, no pun intended, weight into BMI as a measurement of health, and it's not always the best way to go about doing that. So that's a great point to make, and something that we should continue, kind of adapting in order to fit our patients' needs. What other questions do you guys have? These are some really, really good ones. Is there any that someone put in the chat that I forgot to look at? I'm just kind of scrolling through right here. Sometimes I miss them. Is anybody applying this cycle? Kathy is, okay. Awesome. How is it going for you guys? Stress, yes, I totally relate. I did not get accepted to my current school, and this was the only school that I was accepted to until April 16th in the cycle. So it was a long wait for sure, but you just got to keep hanging in there and take care of yourself, and remember that anything that you can do to bring you joy and happiness is worth doing in this time of uncertainty.